Thank you, Dr. Harada, for introduction. Good afternoon, ladies and gentlemen. It is a great honor to be here and make a presentation in such a wonderful chance. My name is Kaori Koga from Chiba University, and the title of my talk today is Management of Endometriosis-Related Infertility, Commentary on Japanese Guideline and Our Experiments. There is no COI to be disclosed. So let me begin my talk by answering question 2, why does endometriosis cause infertility? Firstly, endometriosis reduces the chances of sexual intercourse due to the pain. Endometriosis also reduces tubal functions due to adhesions and inflammation. In addition, endometriosis decreases ovarian function due to inflammation and fibrosis. And finally, although endometriosis is not a disease in the ectopic endometrium, recent studies have shown that endometriosis reduces the endometrial resistivity due to endometrial dysfunction, such as progesterone resistance. Then how can we solve these problems and improve fertility? Let's imagine that we are in a battle against infertility associated with endometriosis. And I would introduce 3 weapons that are assisted reproductive technology, or ART, hormonal treatment, and surgery. So let's take a look at one by one. Firstly, ART can overcome problems with intercourse and tubal factors by bypassing these pathways, and might overcome ovarian function by getting more eggs by controlled ovarian stimulation. And ART could also possibly overcome endometrial resistivity by using hormonal replacement and frozen embryo transfer. The rest of my talk will be based on clinical practice guidelines for endometriosis in Japan, which were revised 2 years ago for the first time in 11 years. These guidelines contain in total 22 CQs, and 5 CQs are related with infertility, and I'm going to introduce them. And this paper is recently published in JOGR, so I'd like Neil and Luke to know this paper. So CQ 12 is ART effective in infertility associated with endometriosis? The answer reads, ART for infertility associated with endometriosis is as effective as ART for other infertility factors, and care should be taken not to delay the start of ART. So this is a strong recommendation to do ART. How about hormonal treatment? As you know, all medications used for endometriosis stop ovulation and cannot be used during infertility treatment. So their effectiveness is limited to special occasions, such as the use of GnRH analog before assisted reproductive technology. There is a CQ on this topic in the guidelines. CQ 13 is hormonal treatment effective in infertility associated with endometriosis? The answer reads, there is no evidence that hormonal treatment is effective before general fertility treatment. Number 2, there is some evidence that hormonal treatment is effective before ART, but further studies are needed to determine the optimal duration and drugs. So basically, hormonal treatment are not recommended during infertility treatment. So how about surgery? Surgery can improve tubal function by adenoadhesiolysis. And there is a CQ on this topic. CQ 11, is surgical treatment effective in improving fertility in infertile patients with peritoneal lesions or mild endometriosis? The answer reads, surgical removal of peritoneal lesions improves pregnancy rates. Therefore, laparoscopy is recommended in cases of infertility and suspected mild endometriosis. Surgery, especially for done for deep endometriosis can also reduce pain at intercourse. And it has been shown that many studies that surgery can improve the rate of spontaneous pregnancy. Interestingly, a number of studies have also shown that surgery improved the rate of pregnancy with subsequent ART. This suggests that surgery may somehow improve receptivity of the endometrium, possibly by improving the pelvic environment. We have CQ on this topic. CQ10 is surgical treatment for deep endometriosis effective in improved infertility. The answer reads, surgical removal of deep endometriosis may improve pregnancy rates. And the reason why the sentence puts the word may here and the recommendation level is C, but not B, is that these surgeries for deep endometriosis are very high risk of complication, as Luke pointed out in his previous talk. Lastly, I would like to discuss whether surgery can improve ovarian function. And I would introduce the guideline CQ9. Is surgical treatment for endometrioma effective in improving fertility? And the answer reads, surgical treatment for stage 3-4 endometriosis may improve fertility. Number 2, removal of ovarian endometrioma does not improve pregnancy rate via ART. This means that if you have decided to go to ART, surgery for ovarian endometrioma is not worth to increase the pregnancy rate. This guidelines also contains a flow chart, which is my favorite. If the patient is young, in this case, younger than 35 years old, and ovaries, tubes, and partner semen are all fine, go to laparoscopy immediately. And at laparoscopy gives the EFI, Luke and Neil have already discussed before. Endometriosis fertility score, according to this score, you can discuss with your patients whether to do expected management for longer or to do jump to ART. If the patient is of advanced age or the patient is young but has any of, number 1, reduced ovarian function, number 2, tubal factor, number 3, male factor, but has no ovarian cyst nor pain, then go to ART immediately. If the patient has pain or has a large endometrioma that are at risk of rupture, infection, or cannot be ruled out for malignancy, do laparoscopy first, then go to ART. But in many cases, it is difficult to decide whether to jump to ART or to do surgery first prior to ART. So let me introduce our experiences. When we jump to ART without performing surgery, in the presence of endometriosis, we have to transfer the embryo, but this may cause complications such as persistent pain, infections, obstetrical complications. And I remember Luke said the infection or rupture is not as bad as without surgery, but we have many cases with serious infection. So I don't think it's negligible. But what if we perform ART after surgery? You can avoid endometriosis-related complications. However, when you're performing ART, you may notice that the ovarian reserve is no longer very low. So in order to avoid this issue, we propose ECBS or embryo cryopreservation before surgery. That is, before surgery, when it still remains ovarian reserve, oocyte pickup and embryo cryopreservation cryopreservation is performed, and then surgery is performed, and transfer the thawed embryo so that the chance of endometriosis-related complication can be avoided. So in our institute, we opt ACBS unless the patient has large endometrioma interferes with oocyte pickup, endometrioma suspected malignancy, strong pain associated with endometriosis. Recently, we conducted a retrospective study where we analyzed 18 cases, underwent ACBS, and conducted a retrospective study with background cases that did and did not become pregnancy were compared, and the ROC curve was drawn to obtain the cutoff value for a desired number of frozen embryo. And we found that the total number of frozen embryo was significantly higher in those become pregnant, which is not surprising, but there is no difference between the groups regarding age or serum AMH. So the number of total frozen embryo was important. We also drew the ROC and found that the cutoff value was 5. Therefore, the total number of frozen embryo was significantly higher in those become pregnant. So we concluded that it is desirable to freeze at least 5 embryos in this ECBS system. I would like to finish my talk by proposing that we must choose the right weapon at the right time and in the right order. Just because you're good at it doesn't mean that you can perform unnecessary surgery or art at the wrong time. And when we plan for the management, we must carefully weigh its benefits and risk. And we need to maximize these weapons' effectiveness and minimize their risks. Thank you for your attention, and I'm happy to take your questions.
Thank you, Professor Koga. Any question or comment? Okay. Yes, Luke, please.
It's an excellent talk. Congratulations. I couldn't agree more, and I'm sad that I didn't actually. Well, I mean, it's good for you that you could actually raise this important point, because it actually is crucial that people, as Neil has pointed out, that there are obstetrical complications if you have endometriosis. So we know that the risk of placenta previa is already increased. It's probably increased even further if you do IVF. And yes, you're right. We can do the easy bits to some extent. Do the egg collection. Make sure that the woman has a decent number of embryos in the bank. We call it embryo banking. And once she's comfortable with that, then you can proceed to the more risky operation of removing the endometrioma, because you know it's going to have an impact on their fertility. And I would even argue in those centers that have access to it, if you're going to do the laparoscopic surgery on the endometriomas, perhaps even at that time, consider taking some, because often you remove a little bit of healthy cortex during that procedure. Make sure you have a team available to perhaps even store ovarian tissue at that time.
Thank you. Thank you. We haven't stored the ovary and frozen, but we only take oocyte. But in the future, maybe we can also preserve the ovary tissue as well. Yeah, that's a good idea. Thank you.
Any other comment or question? Oh, yeah, please, Neil.
Well, just a brief comment. A brilliant presentation, Kaori. That's wonderful.
Thank you.
And I think it just really, I think all three of us are more or less saying the same thing, actually, that that there are different options, and we just need to be careful about minimizing complications and maximizing chance of success. as well as, as Luke mentioned earlier, our patients have values as well that must be respected. So wonderful presentation.
Thank you, Neil.
No more question because, oh yeah, please. Luke?
Well, if you don't have questions from the room, I was just saying that I've been interested to follow some groups, I think mainly in Europe, looking at different ways of dealing with endometriomas. I mean, we know that ablation is probably putting the patient at an increased risk of recurrence and recurrence of pain and possibly lesser outcomes. And the group of Professor Horace Roman in Bordeaux has recently published a really nice, I think, 9 or 10-step video on how to treat women with ethanol sclerotherapy, which is a much less sort of radical type of treatment. It's not like the recurrence rate is 0, but I think I've certainly done it twice with good success. So I think for those women where you're really worried, they may have already had surgery on the other ovary, and now you are going to need to do it on the contralateral one. That was the case in my patient. I was really concerned about what we'd be doing, so we offered that. And then certainly when I talk to colleagues here, there's a lot of them that now are adopting Professor Jacques Donnet's view that if you're going to do excision, accept that you don't need to be radical. If it doesn't strip out easily and you come to the base of the cyst, close to the hilum where all the blood vessels are, except that maybe you just leave it. You just leave that, just burn that to whatever diathermy, low energy that you have, but maybe pull out rather than wanting to be radical, because you potentially really jeopardize these patients' ovarian reserve for good.
Thank you, Luke, for a very important point. So when we say surgery, it's not, one way. There is a lot of method, a lot of way to perform surgery. So we also try not only the peeling, but also some people just evaporating. Some people do ethanol puncture. So I think like radicality and reducing recurrence rate and preserve as much follicle as possible is always like trade-off relationships. So it really depends on the purpose of the surgery. So in order to, reduce the recurrence and try to complete surgery, maybe we better to peel. But if we like temporarily or just reduce the size, but try to avoid the reduction of ovarian reserve, maybe we will opt just puncture or evaporation. So it really depends on the situation. And this is again another type of weapons. So we have many ways to do surgery. So thank you.
Professor Koga, do you have any data about sclerotherapy, ethanol?
In our institute, we have no experiences, but I know many Japanese institutes try that, and some institute report a good result. Good outcome. So not really higher recurrence rate, but ovarian reserve outcome is not bad. So maybe there's like tips or like way.
I think it's also a surgical technique that's probably more easily mastered, because doing the stripping of a relatively large endometrioma is not easy if you want to do it well. But the sclerotherapy is probably something that's more accessible for more surgeons, and ultimately that also is an important factor.
That's true. That's true. And also you don't have to like general anesthesia. You can do like local anesthesia. So some like IVF clinic without hospital or without general anesthesia facility they can do. So it's easy way and not bad.
In many Japanese IVF clinic, they are doing that puncture and just
local anesthesia.
washing or
Right.
put some ethanol.
Yeah, that's right.
Okay. So, any question? Okay, thank you, Professor Koga.
Thank you.
Thank you very much.